I realized as all of this information was coming out about the Inflation Reduction Act, if we don't communicate and educate people, there's going to be a lot of people slip through the cracks. And depending on where you're getting your information from, it's either a great thing for the consumer or it's the worst thing in the world for the consumer. So
Exactly.
the truth is in the middle.
Welcome back. I'm pleased to be joined today by John Fox, who worked in corporate financial services for over 20 years, but saw the complexity that clients came across with Medicare and started his own practice to help clients guide through that process. In fact, today we're to discuss the Inflation Reduction Act, passed in August of 2022, but significantly impacting Medicare in January of 2025. He is highly sought after for his expertise and being able to break down complex topics into simple terms. He and his high school sweetheart, Nancy, have been married for over 44 years, and today he enjoys spending time with his 2 daughters and 3 beautiful grandchildren. John, thank you for joining us today.
Well, thank you very much, Taylor. Okay, so the Inflation Reduction Act, it was signed into law in 2022, created $500 billion in new spending, and they're claiming some tax breaks. The Inflation Reduction Act is not just about Medicare, it's also about clean energy, reducing healthcare costs overall, and something to do with taxes, which I haven't studied like I have how it's going to impact Medicare. Currently, you can spend over $8,000 out of pocket for prescription drug costs. That's a significant expense. They're trying to lower prescription drug costs for people overall. When the government started this prescription drug plan, prescription drugs were not included in Medicare. When they added prescription drugs to Medicare, they did not give Medicare the authority to negotiate drug prices with pharmaceutical companies, which makes zero sense to me, but that's how it was for a couple decades. And so now they're trying to initiate some programs so that they're negotiating drug prices with pharmaceutical companies, and that's part of this whole IRA. They're basically redesigning the Part D program, which is going to have unintended consequences, and that's what we're trying to prepare people for now. So I'm not going to spend any time talking about 2024, but 2025, the main part of this is they're eliminating the coverage gap, or also known as the donut hole. And that was probably one of the most confusing parts of prescriptions for Medicare beneficiaries. And there's 2 ways you can get your prescriptions through Medicare. One is through a Part D prescription drug plan, and that's a plan that's sold by a private insurance company. Each company is different. Each one has their own formulary, their own rules, but in general, what happens is the government says if you're going to have a prescription drug plan, you must cover prescriptions in each classification. So drugs that are going to cover cancer, heart disease, high blood pressure, diabetes, whatever the affliction is, these plans must cover a certain amount of medications that will treat those things. They're not required to cover all medications. So when you look into drug plans in your community, there might be 40 or more drug plans available. Each one of them is different. No 2 drug plans are the same. They have different mixes of prescriptions available in their plan. That's why there's competition, and why if you're in the wrong drug plan from year to year, it can cost you a lot of money.
If I can jump in, just from my perspective, how is that changing then pre-Inflation Reduction Act to post-Inflation Reduction Act? Is this better or worse overall for those on Medicare?
It depends on your situation. A very small percentage of people spend more than $5,000 a year on prescriptions. But there are clients that spend up to $8,000 a year on prescriptions. Not very many, but we have some. The unintended consequences of the Inflation Reduction Act is that nobody now is going to spend more than $2,000. Nearly everybody's going to spend more. So that's why it's so important for people to be aware of this and not just ignore the literature they're going to get from their current companies, because that could cause a lot more expense. So with the prescription drug plans now, if the maximum that we as consumers are going to spend out of pocket is $2,000, they're going to have to recoup some of this money somewhere, and I'm going to describe that as we go. So I was telling you about 2 ways of getting prescriptions. One is through the prescription drug plan. The other's through a Medicare Advantage plan that has a prescription drug plan embedded in it. Everything we're talking about is going to apply to both of those. Whether you currently get your insurance through a Medicare supplement with a separate prescription drug plan, or if you get your benefits through a Medicare Advantage plan with a prescription drug plan, they're both going to be the same impact through this. We're also going to have a Medicare prescription payment plan. So people who do spend a lot of money on prescriptions, instead of paying at the pharmacy, they will have the ability to pay a monthly bill to their plan. I'm going to get into that a little bit. And then also the new manufacturer discount program, which doesn't really affect us as consumers very much, but we'll explain it as we go. So currently 2024, current maximum deductible is $545. You pay 100% of that before your plan kicks in. After that, you pay 25%, and then the plan pays the remaining 75% until drug costs reach $5,000. Then you get into this other area where you're still paying 25%. Plans are paying different amounts based on applicable versus non-applicable drugs. Starting in January of 2025, you're going to pay a deductible of up to $590 before your plan kicks in. Each of these plans has tiers. The plan itself has a formulary, which is a mix of all the drugs they cover. Every plan has a different formulary. So once we have that formulary, they classify each of those drugs into tiers, generally 5 tiers. Some plans might have 6 tiers. Tier 1 and Tier 2 drugs are all generics, and generally, you do not pay a deductible for those drugs. So if you're only on generics, this $590 deductible or up to $590 deductible won't apply to you. And there's plenty of people that they're taking losartan and lisinopril, just a couple inexpensive generics, and so the deductible won't apply to them. They may even have no cost at all for the prescriptions. I just met with a gentleman the other day. He's on generics, and on the plan that he's going to be in, he'll pay nothing out of pocket for his prescriptions. But if your drugs are a tier 3, tier 4, tier 5, those are more expensive drugs, then you're going to pay your deductible first, 100% of that. After you've paid your deductible, you'll pay 25% of the cost of your drugs. The plan will pay either 75% or 65%. If it's an applicable drug, then the manufacturer is going to pay 10%. So now there's going to be more skin in the game for the plans and manufacturers. Once you hit that $2,000 maximum out of pocket, you don't pay anything else the rest of the year. It's all going to be picked up by either your drug plan, the manufacturer, or the government. If you get up here in this catastrophic phase, you can see that the government's picking up 40% or 20% of drug costs. So
is it no matter what tier drugs I'm taking, no matter what Medicare plan I'm on, my max amount of pocket will be $2,000 for the year? That sounds like a pretty big deal.
It's a very big deal for those who were paying more than that already. Most people were not.
Most people
were paying much less. Currently, this year, there's a wide variety of prescription drug plans available for less than $10 a month, some less than $5 a month. That will not be the case going forward. It's just going to shift some of these expenses.
Sure. Incentivize manufacturers to price their drugs accordingly.
What I tell people all the time is, a lot of times they're going to say, we would like to both be on the same plan. And what I explain to them is, it would be completely irresponsible of me to just enroll both of you in the same plan because somebody told you they love it. When we do our due diligence and actually do the research for them individually, it's extremely rare to have a husband and wife on the same plan because their needs are completely different. Their meds are completely different. What I tell them is, it's wonderful that your sister or your neighbor loves their plan. That means they're on the right plan. But to just do that would be completely irresponsible. That would be like advising people on their investments without doing risk tolerance and goals. It just wouldn't be responsible.
I'd be curious to ask those spouses how many of them wear the exact same shoe size.
Yeah. Yeah.
No, that's a fair assessment. Thank you.
Okay, so starting January 1, 2025, Medicare will have a $2,000 maximum out of pocket. So this is going to change with inflation from year to year. So next year, assuming inflation doesn't go down, this will go up. If we have 3% inflation for the next 10 years, 10 years from now, the maximum deductible every year would be $2,688. At 5%, 10 years from now, this deductible would be $3,257. Now, you and I both know we're not going to have exactly 3% inflation for the next 10 years or anything like that. It's going to bounce around. What I want people to realize is this 2,000 maximum out of pocket, that's this year only. It will increase every year as inflation increases. Okay, so our next bullet point here, monthly bills will be, if someone joins the prescription payment plan, they will have the ability to go to the pharmacy, and let's say that they have a very expensive drug that they're picking up in January, and they have that $590 deductible. They will not be required to pay that at the pharmacy if they join the prescription payment plan. They'll be able to get the prescriptions immediately. The pharmacist will notify their plan that they are enrolling in the prescription payment plan, and that plan will bill them an invoice once a month. The people who are going to benefit the most are the ones who know they're going to spend more than $2,000 out of pocket this year, and they incur that expense early in the year, let's say January, February. So if they incur that expense in January, we already know that those people will pay $167 a month for the rest of the year for their meds. But most of us are not like that. Most of us have set lower costs to our plans, and then possibly somewhere in the year have a medical emergency or need high price meds. The main thing to understand is whether you join the prescription payment plan or just pay as you go at the pharmacy, you'll never spend more than $2,000 a year or this year or 2025 on your prescriptions.
It's just a matter of how you want to pay it.
Yes, depends on how you want to pay it. For some people, it might be really beneficial for them to pay monthly. For other people, it might become very confusing because the amount you pay every month will change as you add prescriptions throughout the year.
Sure.
Unless you're one of those few people that are going to have $2,000 cost January 1.
Right.
Those ones are very easy, $167 a month.
Right.
Everyone else, their payment will fluctuate based on their meds. So the other thing to know about this is the pharmacist, if you go to the pharmacy and your meds are in that $600 range, they are required to tell you about the prescription payment plan. You're not required to join it, but they're required to tell you about it and inform you how it works. The pharmacies, the plans, they're all going to have calculators to explain what your expenses will be, but it's only going to be based on the meds you're on at this moment. As you add meds, that will change. So here are the 3 phases of the drug plan starting January, the deductible phase. So we already talked about that deductible is 100%. You're going to pay the 100% of that deductible. No deductible can be more than 5. Plans may vary. Many of these plans will not have a $590 deductible. So normally, Taylor, by now, all of us brokers have already seen all the plans that companies have for next year. We're studying them, we're preparing. So far this year, I've seen 2, and I'm licensed with 9 companies. So only 2 of them so far have I seen the plans.
Why is that?
So what they do is they submit their plans to CMS and the Centers for Medicare Services, and they either get approved or not. And if they're not, they sit down with the actuaries and redo. Some of it could be that they just don't want to release them until they're required to, which is October 1st. Starting October 1st, we can discuss plans with clients. We just can't sell a new plan until October 15th. Some of the plans may be changing so much that they really don't want to disclose them until they have to. Because of the Inflation Reduction Act, some companies are shrinking their footprint across the country. They're pulling out of some markets. Some companies have already said they're pulling out of markets completely. We expect here in Washington, we're going to have at least 40,000 people who are losing their plan.
Oh my goodness, 40,000.
That's what we expect. We'll know more later. They're going to get notified very soon, and they have the opportunity to shop around. And there's some good news in one regard. In Washington, if you're on a Medicare Advantage plan and you want to move to a Med Sup, you have to go through underwriting and qualify from a health perspective to go onto a Med Sup. Unless your company that you're with pulls out of the market, then you're going to have a guaranteed issue opportunity. So there are some people in Med Advantage plans who would rather move to a Med Sup. If their plan pulls out of the market, they'll have that opportunity. So you try to look, what are some of the bright sides? And that's one of them. Even though the maximum deductible is $590, doesn't have to be $590. Some plans will have lower deductibles. The initial coverage phase, this is where you've already paid your $590 deductible. Now you're going to pay 25% of your medication costs up until the $2,000 max is hit, and then you won't pay anything else out of pocket. We're going to review the troop or the true out-of-pocket costs here on the next slide. Every January 1, everything resets. So
get your medical needs taken care of during the holiday season if you're that close, right?
That's right. Simple troop example. If in example 1, your plan cost is $20, but the defined standard plan costs $40, even though you only paid $20 out of pocket, $40 will be applied to your true out-of-pocket costs towards your $2,000 maximum. All of these plans are competitive and they have their little niches. It could be that your particular prescription, although the defined standard is $40 for that drug, maybe your plan decided we're only going to charge people $20 for the cost share for this drug. That's wonderful for you because you're saving money and the $40 is counted towards your $2,000. So there's a real possibility for some people that even though the $2,000 maximum out of pocket, you might not pay $2,000 and still get your $2,000 maximum out of pocket. Example 2, the member's plan cost share is $47 and the defined standard cost share is $35. You paid $47 instead of the $35, so that $47 will be credited to true. So what that's telling you is some of these plans are going to charge you more for prescription than the defined standard plan cost share, and some are going to charge less.
And now if I'm on Medicare, how do I know that? Is that going to come on my receipt? Is that going to come in a statement? How do I know what was applied versus what I paid?
You're going to know based on what they count towards troop. This is one of the reasons why it's so important, especially with prescription drug costs. I tell all my clients every year, this is what's appropriate for you this year based on your prescriptions and the form and tiers that the drug companies have. Nothing that we're talking about today will be the same come January of next year.
Fantastic.
So it's a big commitment to shop these plans every single year to make sure they're still appropriate for them. It has nothing to do with how much the plan costs, though sometimes people tell me, well, John, I'd rather have a better plan because some of these plans, $40, $50, $60 a month, and this plan is only $8 a month. I'd rather have a better plan. There's no such thing. It's 100% based on the meds you're on and the formulary and all this kind of stuff. What I do to show people that is I take them to Medicare.gov. If somebody wanted to, they could go to Medicare.gov by themselves, all their meds in there, and Medicare.gov is going to show them the plans that are most appropriate for their individual circumstances. They may not understand it all, but it's going to do that. And it's going to separate them by the most expensive cost to you, including premium and cost of drugs, the least expensive all the way to the most expensive. When I do things for clients, every broker has an opportunity to show you just the plans they represent and not show you anything that they don't represent. I always take everybody to Medicare.gov. I show them exactly what's available. If it's a plan I represent, I can enroll them, that company will compensate me. If it's a plan I don't represent, I just show them how to self-enroll because The whole goal of having a professional advisor is to have somebody show you what's in your best interest and not just what's in their best interest.
Well, that's fantastic. Thank you for highlighting that. That way the client can see clearly you're not biased to direct them to a certain plan. It's Medicare, everything's there. And
Yeah,
there are some in the audience that I know are do-it-yourselfers. Maybe they're chomping at the bit to go and explore it on their own. But for the 99% of the rest of us, myself
yeah.
included, if I were on Medicare, I'd probably want someone who's been there. I'm doing this once every year at most, and you're doing this hundreds of times every year. Is that something you're willing to help people with who are kind of confused by the changes and how it
Do it all
might
the
apply to them?
time. Yep, do it all the time. I would say, depending on the year, 15 to 20% of the people I work with, I don't write anything for them. I just help them self-enroll in a plan. When I very first started, Taylor, I had two companies. I operated the same then as I do now. We'll enroll you in whatever is appropriate, whether I represent that company or not. And the reason I represent 9 companies now is as time went by and I realized we're helping people self-enroll in this company quite a bit, I'm going to get appointed with that company so I can start getting commissions on those,
Win-win.
on the new ones, not the old ones. So that's how over the years I am now with 9 companies. The ones that we only help people self-enroll in a few times, it's just not worth getting appointed with them. Just help people get into the appropriate plan. Because I know 2-3 years down the road, that may no longer be the right plan, but they're still going to need advice. And then when it's a plan that I do represent, I can help them by enrolling them myself. So, okay, additional Part D changes, manufacturer's discount program. We talked about that a little bit. The main thing to know about this is, one, if you know that you are on expensive medications, you don't have to wait until January. In October, you can sign up for the prescription payment plan.
Oh,
Okay. So people don't have to wait. Any of my clients who are on very expensive plans and would rather pay a monthly payment than pay as they go, we're going to have them enroll. You can enroll in the manufacturer discount program any time of the year. So you don't have to do it January 1. You can be just going along just fine and then get blindsided in May with some expensive meds. You can enroll in that plan then.
John, when I hear payment plan, in our world, generally when you hear payment plan, that means pay as you go. Generally, payment plan infers an interest, right?
No, I'm so glad you asked that.
Is that the case here or not?
No, I was going to
Plan
get to that. What's happening is it's mandated by Medicare that these prescription drug plans carry that expense. So there is no interest. That's one of the reasons I said you cannot pay more than $2,000 for covered prescriptions in a prescription drug plan or a Medicare Advantage prescription drug plan. The plan has to bill you, and that, by the way, is still not finalized. Can you set up an automatic draft out of your account? Will they send you an invoice every month that you pay by check? We don't know those details yet still. So that's still, we're very close to October 1 or October 15th when people can start enrolling, and yet we don't have all the details. But there will be no interest. Now, there are some preparations for people who sign up for the payment prescription plan and then don't pay their bill. After 60 days, if you haven't paid your bill, they cannot cancel you, but they don't have to allow you to defer when you pick up prescriptions after 60 days, you'll have to pay for them as you go. You still owe the prescription payment plan payments that you haven't paid,
Sure.
But from that point on, you'll have to pay for your prescriptions that you pick them up. And there will from what we understand thus far, no interest, no financial penalty, but they're going to expect you to pay that payment plan. But as you can imagine, there's going to be some challenges in that for some people.
Okay.
So this used to be called smoothing. Now it's going to be called prescription payment plan. It's not income based. So doesn't matter if it's somebody's low income, high income, or whatever, anybody can participate in the payment plan. Your deductible counts towards the $2,000. So that's good. Premiums do not count towards the $2,000. CMS has not finalized how the Medicare prescription payment plan will operate. We should be getting those details soon. Completely voluntary. You must opt in to participate. Okay. Future negotiated drug prices. These are the first 10 drugs that are going to be negotiated, and they will take effect in 2026. So until 2026, they're still higher price than they need to be. And these are the 10 drugs that Medicare spends the most money on. So they're negotiating these drugs. In 2025, they're going to start negotiating another 15 medications. Those will take effect in 2027. Are the next 15 most expensive drugs. The ones we just showed you, those were the 10 most expensive drugs that Medicare spends money on. These lists, although they have a preliminary list right now, can change based on usage. So whatever drugs are costing Medicare the most money are the ones that will be lumped into these. The goal is to continue to drive down the cost of prescriptions going forward. Manufacturers.
Can I jump in, John, on this? So 15 drugs, 15, 20, 20. Does that mean that's an additional 15 drugs or just whatever the top 15?
No,
so does that
it's additional.
Okay. So we're looking at by the year 2028, 40. So we're looking at 70, the top 70 drugs across Part B and D would be negotiable.
70 plus the 10 that are taking effect.
Okay, right.
In 2026.
So we're looking at 80 drugs that could be renegotiated based on these changes.
Yes.
Not just
billions of dollars.
Billions of dollars on the most common drugs.
Well, they're not the most common, they're the most expensive.
So billions of dollars of savings for the 80 most expensive drugs Medicare people are on.
Manufacturers that don't follow negotiation requirements will have to pay a tax and penalties if they do not fulfill other manufacturer requirements. That is, I couldn't even tell you what the details of that are because that's deep in the weeds. The manufacturers are going to analyze that and see what they can get away with, and the government's going to try to hold them accountable and all that kind of stuff. So how are these drug plans going to adjust to the fact that now they are going to share in the expenses of anything over $2,000? One, they're changing formularies. Their formularies are going to be different going forward. Two, they're moving drugs from different tiers to other tiers. So maybe drugs that in the past have not been very expensive for you, they might get moved to tier 3 now. So now they're going to have a higher copay. The other thing is premiums are going up. I doubt if we're going to see any premiums under $10, probably not even any premiums under $20. The ones that I've seen so far, like I said, I've only seen 2 companies, they've gone up, and it's going to be we'll be able to talk about that stuff in public starting October 1st. I haven't seen $100+ a month plans yet, so that's a good thing. Prior authorization. So that's going to be more common. Doctor says, hey, we'd like to put you on this med. They are probably going to have to go through what's called step therapy, where the drug plan says, we understand they'd like you to go on this drug, but have you tried this drug yet? It's similar, less expensive. And so that's going to be more common as plans using step therapy and prior authorization. So I want to also mention some drugs that are not included in your true out-of-pocket costs, even though your formulary covers them. There are some drugs that Medicare does not cover. Even if your formulary covers it, Medicare says, no, we don't cover these drugs. So drugs for weight loss or weight gain, not covered. Drugs like tadalafil, which in its original form was used for erectile dysfunction. Well, what they found is some of those drugs work great for people recovering from things like pulmonary arterial hypertension. I think I saw something about some stroke patients being treated with sildenafil. But anyway, some of your plans will cover sildenafil for those afflictions, but because Medicare says we don't cover these drugs for any use, they don't count towards your $2,000 cost. Any drug that's compounded, even though it might be a common form of generics, if your doctor wants you to get a compounded drug, Medicare doesn't cover it. So those are just important things to know going forward. That's why we're telling everybody this year, more importantly than any other time, read your disclosures. You're going to get stuff from your drug plans in late September, early October. Read your annual notice of change And if you don't understand it, call somebody. In a normal year, I would say 10 to 15% of our clients will change plans because their needs have changed. Year, I'll be shocked if it's less than 50%. It's going to be important to look at your plan documents and understand them. One of the things that this Inflation Reduction Act does is mid-year notifications. All of the plans are going to be required in probably July, maybe June, to send you a notification, especially if you're on a Medicare Advantage plan, that says, these are all of the benefits you're entitled to. These are the benefits you haven't utilized yet. Maybe it's going to a fitness center. Maybe it's a chiropractic benefit or whatever it is. Some of your things like preventive maintenance and colonoscopies. So they're going to just have a list of things that you're entitled to that maybe you haven't taken advantage of. Maybe because they forgot, just, oh yeah, I need to take advantage of that. Main thing to do though is to make sure you look at that annual notice of change and not ignore it, because that's the tendency is for people to just, oh, that's not important. But this year it's very, very important.
Can you think of a more crucial year to evaluate their Medicare plan than going into 2025?
This is going to create upheaval in the industry. No matter how much we educate and share this information, there's a segment of the population that's not exposed to this information. And they tend to be procrastinators. They know who they are, right? They won't find out until they go to the pharmacy in January or February of next year. All we can do is the best we can do. But the people that wait till last minute, all of us brokers are just going to be taking care of our own clients. And then you're going to try to absorb the people that come to you because of referrals or because of panic or whatever, because they need help. We're kind of like CPAs in a way. From October 15th through December 7th, it's 6 and 7 days a week, 12 plus hours a day, because you're trying to take care of everybody.
Right. And
it's the only time of the year I feel like I work for a living.
It's a good problem to have, I guess. If I could recap, on average, 15% of those on Medicare plans rotate in or out of plans. But going into 2025, you'd be surprised if it's anything less than 50%.
I just know for me, because I do reviews with my clients, I'm going to move 10 to 15% of them just because the plan that they're on now is no longer appropriate. And that might not have anything to do with the plan itself. It could be that their meds changed and that plan is no longer appropriate just because the meds they're on are not favorable in their formulary or in the tiers. It doesn't mean it's a bad, and this is what I always tell people. There's not a plan that's better than the others. It's what's the most appropriate plan for you this year, because that's what it's based on. It has nothing to do with one plan's better than the other. It's very rare when you're going to have two spouses on the same plan. It happens, but it's not common.
No, that's great. Thank you. I had two questions, if you don't mind.
Sure.
One was, I was reading up, it sounds like there's going to be a cap on insulin, $35.
There is.
Is that true? And can you speak to that for a moment?
Yeah, so that is current. It's wonderful. Covered insulin's $35 maximum out of pocket. The other nice thing about that is your deductible does not apply to that. So even though insulin is more expensive, you don't have to pay your deductible before you pay your $35 for your insulin. And that's been going on for a few years now.
Okay.
Yeah.
I understood that was a new change, but thank you for clarifying.
Yes. And what was your other question?
We talked about earlier, a lot of our discussion has been around prescriptions. And earlier you talked about Medicare Advantage plan specifically. If I were to put on my fifth grader hat, and if you were to break that down even more for me, how can I better understand, or how would you position what the change is to the Medicare Advantage plan?
Well, from the two plans that I've seen so far, two companies that I've seen so far, many of these companies have multiple plans. They might have 4, 5, 6 plans, Medicare Advantage plans in the market, and most of them are zero premium. Okay, so going forward, it looks like you're going to have a couple plans to choose from. Maybe a zero premium plan that's kind of stripped down from all those extra benefits, and it's more of a pure health plan with few frills. Then you might have another plan that has a premium to it, and we don't know yet what those premium ranges are going to be. With those, you'll have access to more things like maybe chiropractic, maybe a fitness center, an over-the-counter benefit where you can get things from a drugstore like bandages and vitamins and things like that. So maybe dental, vision, hearing, stuff like that. Plans have been very generous for the last 5, 6, 7 years, and that's going to change now. It looks like we're weeks away. Here we are at the end of August, early September, right around the corner. We're going to know this very soon, but I wish we had more answers. Like I said, usually by now I would have a clear understanding. We wouldn't be able to talk specifics until October 1st, but
Sure.
we still don't.
Lots of changes in the air.
That alone should clue people into how important it's going to be to really look at your plans this year.
I completely agree. Sounds like you're a great resource. What's a good way for people to get a hold of you if they're wanting to follow up with questions or they'd like you to look at their Medicare plan?
They can call me at 509-990-1886. And then my email address is johnfoxtsp@gmail.com. If they just want information, they can go to my website. It's a great resource, and that is weknowmedicarespokane.com.
Fantastic. I'll put that phone number, your email, and website in the description of this video so people can reference it.
Thank you.
Was there anything else? We covered a lot of ground today, but is there anything you've given this presentation a number of times before? What general questions come up that you'd like to respond to that maybe haven't come up already?
I think the questions generally are just people, when you do a presentation, they want to know exactly how it pertains to them. A lot of those types of questions, I'll have to just talk to them separate because that's what people are more concerned about. Well, how's this apply to me?
Exactly.
The other thing I would say is people new to Medicare who aren't yet on Medicare that are turning 65 soon. It's important to be educated. Let somebody actually educate you and not steer you, because there's two paths. There's the Medicare supplement with the prescription drug plan, and there's the Medicare Advantage plan with the prescription drug plan embedded in it. When you ask people which one is better, it's very much like so many things in life nowadays where you're either for or against. But the truth is, it's not that one's better than the other. They both have different consequences. My goal when I meet with anybody, whether they're brand new to Medicare or already on Medicare, is to explain the two paths and what the consequences are of each and let them decide which is appropriate for them. That's how you become happy with your plan. You don't want to make those mistakes by being uneducated. I think the most important thing I do is educate people and let them decide what's appropriate for them. When you have two spouses in a household, they don't always choose the same thing. They're choosing different things because their needs are different, their health is different, all that kind of stuff. I sure appreciate you allowing me to share this information, and hopefully we'll have some people that benefit. They're going to open their mail this year.
That's right. Hopefully we can get this message out to as many people as possible so everyone can double check their plan. Best case scenario, they don't need to change anything, but either way, they should definitely confirm they're on the right path. Thanks for your time, John. I really appreciate it.
Sounds good.
If you found today's discussion enlightening, please subscribe so you can receive additional updates of the interviews I'll be conducting with other attorneys, real estate professionals, mortgage brokers, Medicare brokers, and more professionals that are all designed to help you retire well. Thanks, and I'll see you in the next one.